Hello, everyone, and welcome to our live breakout session on sustainable strategies for intensive cardiac rehab and virtual cardiac rehab. We hope you've enjoyed the CV Trans Forum, and thank you so much for hanging in to hear this excellent presentation. It's going to be very, very good. The pandemic has really had a crushing blow on center-based programs, with more than 70% of programs closed during the pandemic and more than 3 million exercise sessions missed. And although some programs are back up, many are still struggling with capacity issues because now we have to keep our patients physically distanced. So just a few housekeeping issues before we start. We are going to try to reserve about 10 minutes at the end of the presentations for a live Q&A session. Please use the chat feature as you have in all the other sessions, and use that for your questions, and then we'll give them to the speakers at the end of the presentations. If you need help or technical support, just use the Get Support under Help tab, and don't forget that you can download these great slides in the Files tab. On the next slide, we have our CME information. It is approved for 0.2 CME credits. To claim those, you need to go to the Education Credits tab on the virtual site, download, complete the form, and then submit it to Lindsay to get your certificate. Okay, and so we're really fortunate to have two programs here to share their strategies today. First, we'll have Brenda Hulbert from South Denver Cardiology Associates to start us off. Then next we'll hear from Beth Kramer and Dr. Srinivas Murali from Allegheny Health Network. They're going to discuss the use of virtual CR using the Moving Analytics platform. Okay, and I will hand it off now to you, Beth. Thank you.
Actually, I'm going to start, Brenda.
I'm sorry, I'm Brenda. I knew.
You threw me there for a minute, just a minute.
Sorry about that. It's all you, Brenda.
There you go. Thank you all. And I really appreciate you inviting me to speak on this topic that is very near and dear to my heart and has been for a very long time. This crowd is certainly very well-versed in cardiac rehab, but just kind of a start off to set the stage. We all know that cardiac rehab is a comprehensive secondary prevention tactic designed to improve cardiovascular health following any kind of a cardiac related event. There are two types of cardiac rehab, which we're going to talk about in a little bit more detail a little bit later on, but that is traditional cardiac rehab and intensive cardiac rehab. We were a traditional site up until a few years ago, and then converted to intensive cardiac rehab. We are clinic-based. We are very heavily involved with our health system, but we are not actually under their provider-based license for the cardiac rehab program due to state licensing issues and separate areas and things like that. We all know that participation in cardiac rehab reduces the death rate for mortality rate for all cause, and particularly for additional cardiac events. It also improves functional status, quality of life. We've known that from the early 70s, and also makes people feel better and just do better overall. So why doesn't everyone go to cardiac rehab? That's really the focus of a lot of things that we're doing now in cardiac rehab. Only about 10 to 34% of patients who are eligible for cardiac rehab actually attend cardiac rehab programs. And that varies depending on parts of the country. It depends on, even inside geographic areas, the demographics in the different parts of the areas. The barriers, which we'll talk about in a little bit more detail, but obviously needing to go to work, needing to pay high levels of copays. Even though insurance does cover cardiac rehab, the copays are a little high. And some of the rules, i.e. having physicians, providers in the area during the actual cardiac rehab program, limits the amount of times you can have it at night, that you can have it on the weekends. There's not all programs are lucky enough to have physicians who are willing to be in the area during those hours. So a coalition set up by, as you know, by CDC and CMS, the Million Hearts Initiative, actually their goal was to prevent 1 million heart attacks and strokes before 2022, or by the year 2022. And one of those initiatives was to increase the use of cardiac rehab, and the goal is to have it increase up to 70%. So that's part of what we're hoping to gain, even by having this discussion today. Next slide. The evolution of cardiac rehab, we actually started back in the 50s, and I can say we started back in the 50s because was well aware of that time era. But the real impetus for cardiac rehab started in the early 70s when actually Medicare was the first to approve the coverage for cardiac rehabilitation. And back in the 70s, the cardiac rehab programs were actually 9 months in length instead of the current 36 weeks. That was a long time with patients. That was actually how I started my career with South Denver Cardiology, was in their cardiac rehab program. And then as the indications advanced, programs started to increase both in hospital and in private care across the 80s. And then it was even more comprehensive programs that came into being in and around 2010. Next slide. The traditional cardiac rehab, we all know, has only the component of exercise that is actually reimbursed by CMS and the insurance carriers. The intensive cardiac rehab wanted to take it further and increase the level of education, knowledge, stress management work. So they started working with CMS. And during that time in 2010, they had to prove that their program was beyond what traditional cardiac rehab could do, that it actually lowered the risk factors for the go forward, it slowed the disease progression, and it reduced the ongoing need for bypass surgery. Next slide. They had to meet, and these were the criteria that they had to show, that they were able to reduce triglycerides, the LDL, body mass, systolic blood pressure, diastolic blood pressure, and that medications actually were decreased with those patients who attended intensive cardiac rehab. Next slide. There were 3 programs that actually accomplished this for CMS, and these still remain the only ones that are certified as a ICR program. The Benson program, Ornish, and Pritikin. We started out after our traditional cardiac rehab program as an Ornish program, and we were that type of ICR program for about 18 months. It did not work well for us and our population. So after seeing the Pritikin program at the Medaxiom meeting several years ago, we decided to change our program over to the Pritikin program, which is what we are in now. And we are 100% Pritikin. When a patient comes into the program or is referred to the program, we explain to them that they are being entered into ICR. We no longer routinely do a traditional program. Many programs do a hybrid. We just felt that was too difficult and very hard for us to manage. Next slide. The actual differences for those who may not be as familiar with ICR. In traditional, it was mostly exercise. You attended 36 sessions. You were generally at the office for about an hour, 3 times a week. Now with ICR, they actually come and attend their exercise session, and they have 1 or 2 education sessions along with that at the same time. And you'll see some slides of how that looks. You have, in order to be able to bill for the education under the ICR program, you have to combine it with exercise. Patients just cannot come in for education alone. They have to have education combined with the exercise sessions. Next slide. Qualifying events for ICR are exactly the same as for traditional, and you can see those listed here. It's no surprise, it's what we've had since the early 2000s as far as everything except for chronic heart failure, which has been in the more recent years. Next slide. So the true differences between cardiac rehab altogether, we're gonna move this slide through very quickly. So again, 36 versus 72. We are actually in those 72 sessions have to be completed within 18 weeks, whereas you have 36 weeks to complete the 36 sessions in traditional. In traditional, you can have a limit of 2 sessions billable per day, whereas in intensive, it is 6 sessions per day. Everything else stays the same. It's a supervising physician requirement. Everyone has to have the same individualized treatment plan. It is EKG monitored. The main difference is that there is a required and comprehensive lifestyle education. And in a private setting, this is pretty much the only way that cardiac rehab is financially sustainable. The reimbursement is almost 4 times what it is in traditional cardiac rehab. So obviously that makes it much better. We had our entire time, we provided education for our patients, but we were never able to reimburse for it. So once we became ICR certified, obviously it made it easier to be able to pay for those resources that we had already been supplying without cost. Next slide. So this is pre-COVID. You can see that there's a lot of very close interaction. This happens to be a patient talking to one of our exercise physiologists post-COVID or during COVID as we are in now. Next slide. Looks a little bit different. And so what we've had to do is you can see back against the windows, you can see these mirrored planters. Those actually separated a very large room into the cardiac rehab component, and then we had a wellness area, so it was kind of like a phase 4 cardiac rehab for patients who had been with the program, or even in the community could come in and actually pay a set amount per month and exercise in the facility. When COVID started, the first thing we did before closing was we said, all right, we're not going to have the phase 4. We're going to open up this entire room and we're going to socially distance and we're going to be fine. 3 days later, we were closed 100%. So, but this is the way we remain. We still are not open to that phase 4 advanced program. And you'll see some other slides that show some differences that we've made as well. Next slide. So this is the way it used to look. You can see those planters. You can see the patients exercising behind those planters, a whole other area about the same size. And then next slide. Here's what we look like now. So everybody we're actually shooting from the back of the room now. And you can see how far apart the patients are. And obviously everyone is masked. Next slide. So the intake session pre-COVID, we always had the patients come in person. We have switched that now, and every person that we do the intake on, we do the entire intake via Zoom. Next slide. So here's how we changed what we're actually doing. Pre-COVID, they used 18 pieces of equipment. They were all pretty close together. We had a maximum of 12 in any class. Currently, they're using all 36 pieces of equipment. And we've changed how we're doing the actual warm-ups and exercise sessions. They're only on 2 pieces of equipment instead of 3. And then we have no more use of the free weights because it is very difficult when they're spread out as far as they are. We now have equipment that is numbered, and it tells the patient whether or not that unit has been cleaned or not cleaned, what they can move to in their next session. Next slide. This is what's very different. Each patient has, first off, they're asked not to enter the area until their actual set time, so that we don't have extra people in the room. We are now using disposable blood pressure cuffs. So each person, when they start the program, is assigned a cuff and has their name on it. They also have their own little carrier pack that they keep in a Ziploc bag that they take home and transport back and forth. We don't store anything now, whereas we used to. They each have their own areas, so to speak, that are wiped down and cleaned. You can see this is person number 3, so he has number 3 monitor. He knows that's where he is to go when he gets there, and that stays his place the entire time during the session. Next slide. So here you can see the process, going to their numbered check-in station. The staff then goes to the patient, and you may or may not have seen by that earlier slide, our nurses are in face masks and shields. They are a little bit more nervous, obviously, because they're seeing the same people. They're very close to them. Next to the echo techs, they're the ones that are the closest to the patients. So we did put them in shields as well as masks. We did have one patient test positive. It did not go beyond that patient. Obviously, we symptom watched and had to let all the patients know that were in that time frame that there was a potential exposure, and they would have to symptom watch as well. Next slide. So this just shows what the labeling of the equipment is, as I was talking about. They all have their clean or used cards, and they, for the first time, they have to go to a piece of equipment that is labeled number 1. While they're on number 1, number 2 equipment is being cleaned, while they're on number 2, number 1. So they're seeing us all the time clean, which is a continual and ongoing process. Next slide. So again, it seems like all we're doing is cleaning. It is constant, never ending. Next slide. So here's the education component. Pre-COVID, this happened to be a cooking demonstration. You can see napkins on the table because we used to demonstrate, and then we used to be able to hand out samples so patients could actually taste what we were cooking and have the recipe for it and know what it was like, and therefore want to go home and do that. Next slide. This is what we look like now. So patients are required to wear masks during this time. We're far more spread out. We're no longer doing cooking we are doing the cooking demonstration, but we are not doing any sampling. So they actually see how it's made, but they do not see, they're not able to taste. Next slide. One of the things that actually became very beneficial, we can load this slide. This is actually the components, the full components inside the video library, which for our patients during COVID actually became very, very important. I'll talk a little bit later, and you'll see some slides that show once we were able to kind of get things moving. Normally, these are not available to the patient on the web because they go through them primarily when they're at the office during their sessions. But Pritikin opened all this up so that our patients were able to actually see and experience the education side, even though they were not able to experience the exercise time. Next slide. The group workshops are normal. We obviously could not have those when we were shut down. We have since, obviously, as I showed in the picture, we continue to have those. This slide can be loaded as well. I had a little trouble with our slide pieces. Next slide. And we talked about the cooking component. This was pre-COVID. We can move on. Next slide. So this shows kind of an overview of the sessions that we had been having, and then we have this strange blank. We, as I said, overnight, as you all did, suddenly went from thinking, oh, this is going to be short-lived, to, oh my goodness, everything is going to stop in the world. So you can see here, we are starting to ramp up. We opened mid-June. And we are getting very close to business as usual. Some patients still are not comfortable coming in, but they are getting closer at this point in time. Next slide. So the one on the bottom is what I really wanted you to see. The earlier one was billable. Again, I told you that education is not billable under the CMS plan at this point in time. So what you see happening in April and May while we were closed was that the patients were still accessing the education component of the ICR. Next slide. Next slide. The number of rehab sessions that we changed, that was the other piece. We were closed for 2.5 months. We lost about 48. Now we have lost about 48 sessions per week, because what we had to do, we normally had 8 sessions on Monday, Wednesday, and Friday with 12 patients in each class. Now we have had to extend it out to where we have only 4 sessions on Monday, Tuesday, Wednesday, Thursday, and Friday with 12 patients in each class. So that lowers our capability by 48 patient sessions per week, which is obviously a financial burden as well. Next slide. We still continue to keep outcomes during this period in time. Since we have opened, we continue to see improvements. You can see the one thing that I think is very telling, if you can see the one and only red negative, is their QLI, or their quality of life index. No matter what we do in cardiac rehab, I think during this COVID time, that worry and depression and anxiety are still there even in these patients. So hopefully we're assisting with other parts to try to compensate for that. Next slide. So in closing, when I asked of the staff, would you ever go back? And they, no matter how much cleaning they're having to do, they have said they would never go back from ICR, because they just feel it's so much better for the patient. It's so much more structured, and patients are doing well, and it's definitely worth the effort. And it's just the fact that we are working now to try to be creative in scheduling to allow us maximal opportunity. Thank you. That's my close.
Okay, thank you, Brenda, for that wonderful review, and congratulations. I think you guys are doing a wonderful job, and especially navigating through the COVID period. It's remarkable how well you've done. So thanks for sharing that story with us. So the remaining of the program, we're going to shift gear and talk a little bit about a third platform for cardiac rehab, which is a virtual platform. So we want to talk about virtual cardiac rehab. My name is Srinivas Murali. I'm the chairman for the Department of Cardiovascular Medicine at Allegheny Health Network. Can you go to the next slide, please? So we are in southwestern Pennsylvania. Allegheny Health Network is a network of 9 hospitals, and the flagship hospital is Allegheny General, located in downtown Pittsburgh. And through these 9 hospitals, we have close to 1,700 beds. And in addition to that, we are actually opening an additional hospital in a northern suburb called Wexford. That should be open sometime next fall. And then we have a very large network of outpatient centers scattered throughout southwestern Pennsylvania, as well as around Erie, Pennsylvania. Next slide. We are owned by Highmark Health Insurance, which is a subsidiary of Blue Cross Blue Shield Insurance Companies of America. And as you can see, over the course of our time, we have had multiple recognitions from Joint Commission, American Heart Association, CMS, and some of those are shown here. We like to brag about this whenever we get an opportunity. Next slide. So as Brenda very nicely mentioned, cardiac rehab is an intervention that improves cardiovascular outcomes. I think the evidence supporting this is very strong, evidence-based, and this has been known for quite some time. Nevertheless, I think the adoption rate for cardiac rehabilitation, the recommendation from physicians recommending cardiac rehabilitation to the patients has not really kept up with the evidence. We know that it improves life expectancy. We know that it reduces decompensation and disease progression. It certainly improves, it allows us to modify risk factors. It has psychosocial benefit, reduces risk of depression for those patients with chronic cardiovascular disability, and it improves exercise performance and quality of life. And from an economic perspective, it clearly reduces rehospitalization rate, which is a great economic drain for health systems throughout the country. Next slide. So we have traditional cardiac rehab in our institute, our network. So we have 8 traditional cardiac rehab locations scattered throughout our geography. And as you can see, our participation rate is only 37%. Our completion rate is on average 24 sessions, and we serve approximately a little less than 2,000 patients annually. So in partnership with MoveOn Analytics, which is a virtual cardiac rehab company, and in partnership with our parent Highmark, we started a project, and we have done this before in partnering with industry and evaluating innovative ideas in healthcare. And so under that umbrella, we decided to launch this program where we wanted to see if virtual cardiac rehabilitation in our market could improve clinical outcomes, could improve economic outcomes, and could improve patient experience. Now, I must tell you that we started this program before we had heard of COVID-19. So we started last fall, and as you know, as it turned out during the COVID pandemic in our area, when all our traditional rehab facilities were shut down, we were able to enroll a number of patients into this virtual platform, and so that really clearly allowed us to have an alternative solution, which worked out quite well for us. Next slide. So just to give a very brief overview, it has the Moving Analytics platform for virtual cardiac rehab. It uses evidence-based guidelines and clinical protocols. Obviously, it's technology-based, uses smart technology, wearable technology, and communicates with the patient. There are clinical staff who stay in touch with the patient. And we also provide a lot of clinical training through this platform. And technical support is available for those patients who may have difficulty navigating through the technology. And it's an extremely well-organized and well-coordinated program. And despite the fact that we live in a market where our patients tend to be somewhat older, we have been able to see quite a bit of success with this platform, as you will hear in a few minutes. So with that, I'm going to turn the program over to Beth Kramer. Beth is the Director for Cardiac Rehabilitation Services in our network, and she will share some details about this virtual cardiac rehab program and some of the preliminary results that we can share with all of you. Thank you.
Yes, thank you. Thank you, Dr. Morelli. Appreciate it. So I'd like to talk with everybody just about how we actually have implemented this into our current routine that we have with our patients who may have heart disease and are in-house at our facilities. So we start our day, we have the program coordinators who are hired through Moving Analytics that actually look for patients who are eligible for the program from a low to moderate risk perspective with the diagnoses listed here at the bottom, and also going actually into the hospital's bedside, cath labs, and clinics, and getting face-to-face with these patients and offering the approach of the traditional cardiac rehab and also the moving virtual cardiac rehab. So we're offering those two programs, and then the patient selects which one they would actually like to attend and what's best for them. Next slide, please. And as Dr. Malley mentioned, we do have clinical staff on board here that actually work through the Moving Analytics platform and program. As I mentioned, the program coordinator is the first clinical staff that actually touches or gets in contact with the patient. And they really are responsible for that eligibility, defining that, and then onboarding the patient, including working through that application, getting that downloaded on their smart device. They're providing them with some education on the blood pressure scale that's given, the blood pressure cuff, as well as the fitness activity tracker, which is usually a Fitbit or Garmin product. And then they do give once the patient's enrolled, they give a warm handoff via FaceTime from the patient to the case manager or coach that will actually be working with the patient. And this patient or this coach takes it from there. They're the captain of the ship at that point and working with that patient really one-on-one, coaching them, motivating them, and really working with that secondary prevention, mirroring the traditional cardiac rehab based on all the protocols and things we have in place for the program itself all the way through. Medical director is very much involved from the get-go, from whether there's questions with patient issues on enrollment to maybe questions that the coach has about the patient, and if something's happening, what does that medical director recommend? They're also overseeing the program overall, as well as signing off on compliance, plan of cares, and such. Next slide, please. One of the components or pieces that we've implemented working with our traditional cardiac rehabs, we feel like to collect some better outcomes on the patient, as well as look at the patient as a whole, so we can prescribe a plan appropriately and individualized for these patients, is actually having these patients attend an in-person evaluation at the closest or most convenient facility for that patient. So the program coordinator is responsible for setting that up with the brick and mortar staff to have that patient come in and do a traditional evaluation with the patient, face to face, and also participate in a limited submax treadmill test, so we can actually look at their functional capacity as well as vitals and see how they tolerate exercise, so a plan can be completed on that patient. During that evaluation as well, it's a very comprehensive evaluation. They are also working through the platform, the Moving Analytics platform software, and filling out their quality of life assessments, which we have many. Next slide, please. You probably saw a picture of this in Dr. Morales' slide, and I mentioned this here, but this is the package that the patient receives, which is very comprehensive, and it's all smart related, smart technology, and Bluetooth innovative stuff that really communicates with that Moving Analytics dashboard, which is great. So the patient does have to have a smart device, which could be a computer, a tablet, or a phone. They are given by the Moving Analytics staff a fitness tracker, the blood pressure cuff, and the scale, as well as their education booklet that will be gone over with the case manager throughout the program. Next slide, please. Personalized treatment plan, of course, as we assess the patient in that initial eval, all of that information from the brick and mortar setting is downloaded into Epic, our EHR. The case manager has access to that information, and from that information, as well as communicating with the patients more in depth if they need to, they develop a personalized individual plan. And as you can see, it's very robust, very comprehensive, hitting all the risk factors that we need to take care of our patients appropriately. And as you can see, our assessment column, we're, of course, wanting to assess how they're doing in these areas before we provide an individualized plan. And we set goals, basic goals with the patients. And then, of course, being that not every patient is the same, we want to have them start out at a certain place based off of what we know about the patient, how they've done on that treadmill test, their assessments, and then work them through each of these areas. Next slide, please. And then we do give them a home exercise program based on what they have access to, whether it's a gym, whether it's equipment in their home, whether it's, would like to say walking in the mall, but that's kind of like not happening these days with COVID. So they come up with creative ways to work with the patient with what they have access to, and really promoting and motivating them to get out there, you know, do things 3 to 5 days a week with appropriate prescribed exercise intensity and duration. And when they're using that fitness tracker, that's really, you know, looking at that heart rate, measuring their intensity, and communicating back to that moving analytics application. And that information goes directly in there, and the case manager can see that. And we're also requiring them, of course, to report rate of perceived exertion, how hard are you working, any symptoms that they're having. And then, like I mentioned, everything is tracked through that activity tracker into the application itself. Next slide, please. Weekly coaching does take place. It's telecounseling, and a lot of it happens via the phone or text messaging, you know, all working through that smart device and that application. And they're really working on all the secondary prevention touch points here: blood pressure control, nutrition, stress management, smoking cessation, tobacco cessation, weight management, medication adherence, compliance, very important. Really providing that coaching that's emotional and psychological that we know our patients need when they get into these programs, these great programs that we have. Next slide, please. And then, of course, we, you know, want to engage the provider into everything that we're doing. So from a compliance perspective as well, the cardiologist is getting monthly progress reports on their patients. And the coach is using that pretty much to work with that provider on, you know, what do they recommend medication-wise, or maybe the patient needs to see a behavioral health counselor. Maybe they need to go to nutrition counseling and see a certified diabetic educator. All these reports that are pulled together monthly, every 30 days, are actually scanned into Epic, and they can also be faxed to the physician directly. Next slide, please. So with the remote monitoring through the software, of course, this gives you a picture about, you know, who all is involved here. The patient, you know, is reporting everything that they're doing through the application to the coach or case manager, and they're reporting symptoms directly, their vitals, their adherence, all of that is tracked within the software. The coach themselves, of course, if the patient is reaching out and saying, hey, I'm short of breath today, I feel like my weight's up, my ankles are swollen, you know, they're really responsible for getting back to the patient within 24 hours and escalating to the cardiologist if and when needed. And also the medical director is involved and has access to the dashboard. So they are seeing those symptoms come through as well, and reaching out to the case manager, discussing those issues, and getting the patient the care that they need whenever they need it. Next slide, please. We do have set up emergency protocols within the application. We do educate and teach the patients that we do recommend that they exercise within the emergency protocol hours here that we have set up. 8 a.m. to 6 p.m. Monday through Saturday is when the clinical staff is available to help that patient if they're having issues while they're exercising. They are advised to only exercise during those hours, and then they are instructed that if they've chosen to exercise outside of those hours, they are to contact 911 as soon as possible if they're having issues. Technical support is always available and is needed as needed throughout the application as well, if they're having trouble with their you know, software or something's going on with their phone. Next slide, please. And here's the outcomes we have so far from the study, as Dr. Morali mentioned, that we started this last fall, pre-COVID, and we've just stayed steady with everything. We're more than halfway through the study, and I believe we're extending to the end of the year. With that being said, you know, we've grown quite a bit with locations we're enrolling from to diagnoses. You know, recently we got approval to take in the chronic heart failure or stable heart failure patients. And we did do claims data, and we've seen that we've already improved our enrollment. We know this is much higher, but we do have unfortunately, a lag time on claims data with processing of about 3 months. We will not be able to see a full visual of all of our data until probably springtime after the new year, just because of all the claims having to roll out appropriately. But we've already increased our enrollment rate from 37% to 60%. And we know it's more better than that. Graduation rate went from 50% to 86%. And this just goes through our engagement per member with our averages here. So obviously the patients are doing about 108 minutes of exercise per week. The vitals reported, you know, the improvement, social support, anxiety scores have improved, depression. And we do currently have about 109 patients actively enrolled in using the platform. Average time to initiate cardiac rehab went from 49 days to 7.5 days. So as you can see with the virtual program, it's very timely in getting those patients actively engaged ASAP. Very important. A couple of things we have learned during coronavirus, our traditional cardiac rehab programs, just like Brenda had mentioned, had to shut down. And during that time, like Dr. Morale mentioned, we were able to transfer some of our eligible patients from our brick and mortar settings out to the remote program and finish in that program. And we're finding now that these patients who were enrolling from the inpatient side or clinic side, that they have a legit fear of coming in and possibly picking up coronavirus. So we are really working hard to, if we find that patient, to get them into the virtual cardiac rehab. Some patients who have come into our sites have decided that they prefer the remote program over the brick and mortar. We've had patients come in to do their initial eval physically in person, and they say, this just isn't for me. What about that remote option? And we transfer them out. And then we've had patients who maybe aren't sure about remote cardiac rehab on the other end of things. And they say, well, hey, let's, attend maybe some of these brick and mortar sessions. If I want to stay here, I will. But if I decide, yeah, it's, maybe let's try this remote approach, and maybe I have to get back to work and then it's better for me, we offer that hybrid approach as well. So we've worked well together from a network perspective with the third party as well. And it's going very, very well. And we definitely want to look into adopting this approach or other service for our patients to provide them with another option to really take care of those barriers that we have in place for them not attending the program. Next slide, please. And I think that wraps us up. Dr. Morale, I didn't know if you wanted to add anything.
No, thank you, Beth. I think as Beth summarized, I think there is clearly a role for virtual cardiac rehabilitation. I think obviously, irrespective of the impact of COVID-19, I really think that the adoption rate for cardiac rehab continues to be a struggle. And I think engaging patients for long periods of time is often a challenge. And as we look into the future, I would like to see the virtual option either as a totally virtual option or perhaps a hybrid option that may have utility and value. So that patients can benefit from this wonderful intervention.
Absolutely, great presentations. Thank all of you. It was very, very informative, really fascinating to see what you guys have been doing through the pandemic. We did have one question that any of you could weigh in on. Are you expanding your hours or changing your hours of operations to accommodate more patients given the need, to expand space or contract space, I guess?
Well, for us, as I said, we had to expand to being 5 days a week in order to accomplish that. And we expanded our space, technically. We kind of doubled our space and increased our time by 2 additional days. But again, because of the fact we don't have physicians in-house because it's a private setting, we have to stay within the normal Monday through Friday, 8 to 5 time.
One of the things I don't know if you guys can hear me, but one of the things we did from the brick and mortar setting is we actually bought mobile floor to ceiling plexiglass, and our infection control has allowed us to put that in between equipment when we can't social distance, because as we know, expanding our space is not happening. So that has really helped us get back to pre-COVID volume and almost be there. But like Brenda said, we had to really be creative and innovative and, open up 5 days a week and really try to figure out how we were going to function with social distancing. And it's been tough, but we're getting there.
Excellent solution. That's very creative. Outcomes across both programs look really, really incredible. I was really impressed with that time to initiate with the virtual, the 7.9 days. That's really impressive. Have you, are you doing remote intake with any of those patients if they're still concerned about coming into the center?
Yeah, so we are. If they're eligible from an insurance perspective, because we're only enrolling Highmark and Highmark Medicare Advantage at this time, but if they're eligible from that insurance perspective and eligible as a client for low to moderate risk, yes, we will do that.
Great. So how optimistic are you guys that Highmark will begin to reimburse for virtual cardiac rehab? Do you think that's a good possibility?
Yeah,
Yes, I think that the...
Go ahead, Beth.
No, it's good, Dr. Romali. I'm good. Go ahead.
Oh, I just wanted to say that I think we have had previous experience with innovative technology, which which Highmark would evaluate in a similar manner, which has led to reimbursement. So I think as long as we can demonstrate that it improves clinical outcomes and it improves patient experience and the adoption rate for rehab improves as we have shown, if that number stays, I'm confident that we will get approval.
Excellent. Excellent. Great work. Thank you so much. Dr. Morali, Beth, Brenda, you guys have done a great job this afternoon. Thanks for helping us close out what's been a really great conference.
Thank you.
Have a great
Thank you
rest
so
of your
much.
day.
You too. Bye-bye.
Bye-bye.